Welcome to Healthy Frontiers, a show dedicated to the education of our viewers. The topic tonight is living with a healthy, pain-free neck, and my special guest is Dr. Jack Stern. Dr. Stern's a neurosurgeon. He's the founder of Brain and Spine Neurosurgeons of New York. He practices here in White Plains, and I'd like to welcome Dr. Stern to the show. Welcome, Dr. Stern. It's a pleasure to meet you. Before we start, why don't you tell me a little bit about your background?
I'm an inveterate New Yorker.
Okay.
So I went to medical school and got an MD and a PhD degree at the Albert Einstein College of Medicine.
Okay.
And then decided to change boroughs and went to NYU, where I did my surgical training, and then decided to head uptown to Columbia Presbyterian, where I did my neurosurgical training.
Okay.
And for the vast majority of my professional life, I've actually practiced here in White Plains, and I'm on the faculty of the New York Medical College in Valhalla, and at Yale University School of Medicine in New Haven.
Okay, that's an excellent little resume, I'll tell you. So how does the PhD come into play here? Do you utilize that a lot now that you do?
My PhD was in molecular biology. Needless to say, as a surgeon who spends 3 days a week in the operating room and 2 days a week in the office,
right,
I don't get a chance to use that at all. But getting a PhD does allow one to train to think critically.
Okay.
And I think that's very important for physicians and for surgeons, to think critically about a problem, to weigh the pros and cons of treatment, how to further hone down on a diagnosis, and to read the literature critically.
Right.
And I think that the PhD training really helps one think in a slightly more critical manner.
Right.
Yeah.
That's great. We're going to talk about the spine today. Why don't you tell me what a normal spine looks like? Okay, before we get into what's abnormal and why people may need surgery or how they can prevent surgical procedures, tell me what a normal spine looks like. Maybe you can even demo it after a while.
Well, I understand that my younger associate Seth Newbar was on your show a while ago and talked about the lumbar spine.
He was.
So I'm picking up the rear here.
There you go.
Although
maybe the top.
I think he picked up the rear.
He picked up the rear.
As he did the lumbar spine. And I'm going to talk a little bit about the cervical spine.
Okay.
And by cervical spine, we mean those 7 vertebrae that constitute the bones in your neck.
Okay.
And if you look at this model, you'll notice that this is what remains of the back of the head.
Okay.
And so the vertebrae, the cervical vertebrae, actually support the head, articulate with the head,
right,
and have between them discs. Now, it's confusing sometimes as to how we label the discs.
Okay.
Since there are 7 cervical vertebrae, this
Yes.
would be C1, C2, C3, C4, C5, C6, C7.
So counting downward.
Counting downward. The discs are actually labeled by which vertebrae they are between.
Okay.
Not a perfect grammatical sentence, but I think you get the idea.
Yes.
So if this disc is between C2 and C3, we call this the C2-3 disc.
Okay.
And that actually gives mobility to the spine. The bony vertebrae give structure and strength to the spine.
Okay.
Now, the structure themselves, like with all vertebrae in the body, is circumferential.
Yes.
You can actually feel, if this is the back of my head,
Yes.
you can actually feel the spine, what we call the spinous processes. You can actually feel them.
So those little bumps that you feel in the back of one's head is
in the
part
back
of
of
that
one's neck.
vertebrae.
Right.
It's not. Some people will say, "Well, that could be a knot in my neck, doc." But
Well, it could be, but on a day-to-day basis, what
Yes.
you feel in the back of your head, in the back of your neck,
Yes.
are those spinous processes.
okay,
Now, the spinous processes are attached to something called lamina,
right?
and then the vertebrae in front. And they create a triangular structure that surrounds this central structure. And here it's labeled in a yellow color, which is the spinal cord.
Okay.
And the spinal cord is an extension. The brain would be here, and the spinal cord is the extension of the brain.
Okay.
And at each level, it gives off nerves. The spinal cord gives off nerves. Now, in the cervical area, the nerves go primarily to the arm.
Yes. Okay.
And you can actually trace. For example, the fifth, what we call the C5 nerve, usually goes to the biceps.
Right.
The C7 nerve usually goes to the triceps.
Okay.
So each one of the nerves has a very specific function.
Okay.
And that's actually very important to us later, because if a patient comes in with a problem related to one of the muscles, specific muscles,
yes,
we can then trace it back. If that muscle gets its nerve supply from C5,
yes,
you can then trace it back to a problem actually not with that muscle per se,
right,
but perhaps to the nerve that innervates, gives innervation to that muscle. So knowing the function of these nerves is very important in diagnosis and in treatment.
And in the level. So you're saying that there are messages being carried to these muscles, so someone may have pain in their forearm, in their elbow, somewhere along their extremity, and the pain may not be starting there at all. It may be coming from someplace else.
Exactly right. Exactly
Okay.
right. Just to complete the picture,
Yes.
The vertebral arteries run in the bone of the vertebrae, which
Yes.
is an unusual thing where an artery actually runs through a bone, and that then goes up to feed some of the vessels that feed the brain.
Okay.
The spinal cord itself is then surrounded by a very thick membrane called a dura,
Okay.
D-U-R-A, from the Latin word hard,
Hard.
durable.
Yes.
And in that dura is the spinal fluid.
Mm-hmm.
So the nerves and the spinal cord are surrounded constantly by spinal fluid, which is made in the brain and then comes down and surrounds it. The dura, therefore, is watertight.
Right.
Needless to say, on a model like this, you can't demonstrate
Of course.
the one. So in general, it's a protective mechanism. It gives mobility.
Yes.
It once again, it protects the spinal cord and the nerves, protects some of the vessels as well.
And this artery that you're pointing out to me is a special artery. You said it's unusual, and it's unusual because it's the only area in the spine that an artery runs through that
Right,
spine.
the vertebral arteries actually run through the bone.
Okay.
It's an unusual set of circumstances.
Okay. So that if you tweak that, we might have some problems, and we'll talk about those in a
Right.
moment. Right.
The interesting thing also, just anatomically, we also always think of the spine as from the back, and you can feel, as I said, the spinous processes from the back.
Yes.
But in someone like yourself who has a long, thin neck, if I may, I could probably actually feel the front of I actually have my finger on your vertebrae. I actually have my finger right there
On the vertebrae.
on the vertebrae itself.
And if in the back, to feel one of those, you would be touching my vertebrae?
Right
you feel?
here, I'm touching your vertebrae
Now
right
you're touching
there.
my vertebrae.
Right.
Okay. Excellent.
So
Okay.
that gives you a general feel for the anatomy.
Okay, and we notice that many times there's a curvature. We have these normal curves in our spine, and we're born with them, or we're not born with them. They develop, I understand.
Correct.
Correct?
The spine, the cervical spine, and this model demonstrates it, normally has this C-shaped.
Okay.
We call it the lordotic curve. Normal lordotic curve is, or a C shape.
Right.
And one of the things that we look for, particularly after trauma,
Yes.
is that the muscles, and you've probably experienced that yourself when you wake up with a stiff neck
Sure.
and your muscles are tight, that the muscles will then tighten, like tenterhooks at the circus. Those
Oh, yeah,
those
when it holds
wires
the
that
tents.
don't hold it right.
Yep,
hold
okay.
the, and what happens then is that the cervical spine straightens.
So you lose that normal
You
curve.
lose the normal curve, and that's one of the signs that we have when a patient has had a traumatic event.
Okay, so one of the things you look on an X-ray, possibly you'll see a change in that curvature.
Right.
You say, "Oh, something may have happened here."
Right. You may also see some swelling if it's very traumatic, say perhaps a severe automobile accident or something like that.
Okay.
Yeah. So the curve is a nice hallmark of trauma, and it's a nice gentle curve supporting it.
And the lack of would give us a lot of information.
Correct. Exactly right.
Okay, so I think the audience will understand what the normal spine looks like now. What goes wrong? What are some of the non-traumatic reasons why people will get neck pain? All right, I mean, there are tumors. Tell me about some of these things that someone would come into your office and say, Doc, I have neck pain. They start there. You have to be the diagnostician.
Right. Fortunately, I think that the vast majority of patients who have neck pain don't show up in my office because the vast majority of people who have neck pain don't need surgery.
Oh, okay.
I think it's much more likely that they'll end up in your office, in a chiropractor's office, than in my office.
Okay.
In fact, I would venture to say that the vast majority of neck pain is really benign neck pain.
Okay.
Someone wakes up, typical say someone wakes up with a stiff neck.
Yes.
Could they have slept in front of the air conditioner? It's a possibility.
Sure.
And yet, many times patients wake up and say they have no idea why they have a stiff neck. And it's really just neck pain, sometimes on one side, sometimes on both sides.
Okay.
And it may just be positional. I would suspect that it's just positional.
Okay. Might be their pillow.
Right.
Could be their mattress.
Anything, right.
Okay.
Remember, we sleep for hours in the same position. Well,
That's right.
we do move, but in a very similar position.
Right.
Speaking of position, I think the other most significant cause of neck pain
Yes.
is positional.
Okay.
I dread when I walk into an office and there are people sitting there in front of an array of computers, because invariably this is what I see.
Right. Right. Oh, is that a killer, isn't it?
Right.
Oh.
And you just know
Yes.
that those folks are a perfect setup. So I would say that I think the term we use nowadays is it's an occupational problem
Okay.
based on.
I don't know about you, but years ago it would be mostly lower back pain. People were digging and shoveling and
Right.
doing more manual labor. These days, I see so many more people with problems of their neck from the computer age.
Right.
Do you see that?
And of course, the ironic part is that almost all these injuries
Yes.
are avoidable.
Right.
Better attention to the ergonomics, having the computer screen at eye level or slightly below eye
Yes.
level, having the keyboard at the proper
Correct.
relationship to your elbow and to your shoulders can really avoid.
Right.
And I think the third category of neck pain, again, that doesn't show up in my office, and again, is more likely to come to your office of
Yes.
physical therapy, is the weekend warrior,
Okay.
or the athlete, even the high school or college athlete.
Okay.
By the way, we're all aware, although I'm not a particular football fan,
Yes.
of the horrible injuries that we have had the misfortune to watch, where people have had terrible neck injuries on a football field,
sure.
even with paralysis.
Yes.
That's the most traumatic end of the spectrum. But you see, I'm sure in your office,
Yes.
a young man or a young woman, after not playing tennis for 3 months, or not playing soccer or volleyball or swimming,
Yes.
come in with neck
Neck
pain.
pain. Sure.
So those three categories, which are really benign categories,
Okay.
probably constitute the vast majority of neck pain.
Right.
And what's interesting about them is that they're almost probably all related, not to the discs,
Right.
and not to the bones, and not to the nerves,
Right.
but related to the ligaments and muscles that are the supporting structures for the neck.
So important.
Yeah, and even though I didn't emphasize that when we looked at the
Yes.
model, because this model really doesn't demonstrate those, the vast majority of the injuries are related to muscle ligamentous tears, tendinous injuries, and they're almost always treated conservatively.
Right. And then if it gets past that point, those ligaments, tendons are attached to the bone, which attach to the areas near the spinal cord and the nerve structure.
Well,
Right,
I think we all know from experience that
Yes.
soft tissue injury, we call these soft tissue injuries,
Right.
right? Even though muscle isn't really soft,
Yes.
but under the category of soft, are self-limiting.
Yes.
But attention must be paid when a self-limiting injury isn't self-limited.
Okay.
So we know that if you wake up with a stiff neck, invariably in 10 days, 2 weeks, your neck should be better.
Right.
If it's not better after 2 weeks, the wise physician or chiropractor or physical therapist will say, I wonder if there's something else going on. I wonder if that was just there to serendipitously, and I shouldn't be fooled. Perhaps something more serious is going on.
So you have a week to 2 weeks to see. If it goes away, we don't need to get too involved after that. If it's still around,
correct.
Certainly get it checked.
Yeah.
Important.
And what that brings me to, I guess, in a way, is what are the things that are serious? When is neck pain really a harbinger of a more serious ailment? Now, traditionally, we categorize those ailments into either degenerative, that's a product of old age,
Yes.
or traumatic,
Yes.
or tumorous,
Right.
or infections. So if we think about that for a few minutes,
Right.
there are hallmarks that we call the red flags.
Yes.
And the red flags are those issues that say to you or to me when a patient comes in, this is more serious, this requires more attention.
Yes.
And I think for your viewers, it's also important to keep in mind what the red flags are.
Yes.
I think there's nothing as important as an educated patient.
Yes.
Right?
Most important.
So what are the red flags? The red flags are patients or individuals who experience weakness.
Weakness. The arm may feel
Weak. Or nowadays you see a lot of people work out. It wouldn't be unusual for somebody to come into my office and say, Doc, I lift.
Right.
I get tired just listening to them lift. But they'll say, but my biceps, I got some pain in my neck, but my biceps looks like it's getting smaller.
Right.
Or they come in and they say, I got numbness and tingling.
Yes. Okay. That's another red flag.
I can't quite feel. Now, it could be other things. It could be carpal tunnel, many other things. But these are some of the... Now, the more serious red flags are those red flags that deal with not only the upper extremity, but remember the spinal cord is right there.
Yes.
So something that may be pressing against the spinal cord, not just something that's affecting the nerves. And once it affects the spinal cord, the red flags are, Doc, I'm having difficulty walking. My feet feel awkward. Or I'm having trouble controlling my bowels. Or I'm having trouble controlling my bladder.
Well, how does that relate?
Because since the spinal cord, which is which is going through the vertebrae, is sitting right there, something pressing against the spinal cord, which controls ambulation or power in the lower extremities and control of your bowels and your bladder. If something's pressing against the spinal cord, even in the cervical area, it'll manifest itself or can manifest itself in the lower extremities. So the red flags for all of us, whether we're medical practitioners of any kind or the lay public, are things that we should really be paying attention to.
Okay.
And I think then it's the responsibility of the practitioner who sees that individual to develop an algorithm, a plan to make the diagnosis.
Most important part.
Right.
We need to know what the problem is. Where is it coming from?
Right. What level and what's causing it.
Right. I mean, I go back to a question with Christopher Reeve, the poor person, had a cervical problem. Everything below was affected. So that cervical spine is just so important.
Right. It's really key.
Yeah.
Now, fortunately, when we deal with cervical problems that come into my office, I would say the most common problems that we see as neurosurgeons are issues as regards in the elderly, degenerative, say osteoarthritis, so an arthritic spur, calcium buildup, from arthritis, could be pushing against the nerve, could be pushing against the spinal cord.
Yes.
Or a herniated disc in the neck. Right.
What is a herniated disc? Tell me, what is that?
A herniated disc is when the disc, which is in this normal anatomical position, pushes comes out of its normal anatomical position and presses against the nerve. Same,
Okay.
you probably covered it in the lumbar area the other day.
We spoke about it, yes.
It's the same principle.
Okay.
Same principle. Now, if it's a small disc, it might just affect one nerve.
Right.
If it's a bigger disc, it might affect two nerves or the same nerve on either side. Or it could be a very large herniated disc
Right.
and affect the spinal cord, and the patient or the individual comes in saying the things that the red flags.
Yes.
You know, doctor, it started off with neck pain, then I had trouble feeling or having loss of strength in one arm, but now, you know, I'm embarrassed to say, and people are embarrassed to say, so you have to ask specifically,
Yes.
I'm having some trouble controlling my bowels and my bladder. And even more, you have to ask specifically because men are also embarrassed to say, I'm having some trouble with erectile
Not
function.
only embarrassed, oftentimes I'll find they don't even think of the connection.
Right.
Right? So that's our job.
Right.
Bring that out.
To bring that,
you know?
Right.
Really.
Right. And even the healthcare professionals, I think less so today than probably when you and I trained,
Yes.
were somewhat reluctant to ask those sensitive questions.
That's so true.
Right.
It's so true.
Right.
So if a person needs surgery, okay, they've exhausted maybe chiropractic care, they've tried other alternative methods, they've stopped exercises, started exercising, and those things haven't worked, and now they're in your office. What?
In that case, I think it depends on what the diagnosis is.
Correct. If we assume the diagnosis is, okay, it's a surgical, for your
Well, let's say most of the diagnosis we have, whether it's degenerative, can usually be treated with conservative measures.
Right.
Not unlikely
Right.
for me to send it to a physical therapist, send it to a chiropractor, exercise program, stretching
Sure.
program. Even herniated discs,
Yeah.
for the most part, can be treated with traction, perhaps a steroid shot or a steroid
Yes.
injection. Tumors, of course, cannot be treated for
Right.
the most part conservatively. And trauma,
Right.
I mean, if God forbid someone breaks their neck, you're not going to say, well,
Right.
let me send them to with all due respect, to the chiropractor.
That's for sure.
So the vast majority of the cases we see are benign conditions. That's a herniated disc, since it's not
Right.
cancerous.
Can
we call
that
it
heal on its own?
It can. That's why I think it's so important to examine the patient,
Yes.
because you would be most reluctant to treat a herniated cervical disc conservatively if that patient has significant weakness, or if that patient's complaining about bowel and bladder problems.
There's the key. Those red flags we just spoke about.
Yes, if they start to demonstrate the red flags, you're probably beyond, not always, but probably beyond the point of conservative treatment.
Right. Right.
Yeah.
Okay.
And I think the other indication for surgery is those patients who have none of the red flags, but who may have a herniated disc,
Right.
are in so much pain
Yes.
that neither the chiropractor, the physical therapist, or even sometimes the pain management person,
Yes.
specialist can get them out of pain. I'm much more reluctant to operate on that last category because we all know how subjective pain
Right.
is.
Yes.
I'm a big wuss, so the least
Yes.
bit of pain, I'll want my surgery.
You're right.
But there's some folks who require, have a tremendous pain tolerance.
Right.
So you have to, as a clinician, you have to judge that very carefully, and try to tailor that to every patient.
Okay.
Yeah.
And now if they come in your office, I know there are different types of surgeries. There's a spinal fusion, which is done quite frequently when needed. There's something now, disc replacement, that's been in vogue. And tell me a little bit about that. This is one of the newer techniques, I understand.
Right.
And what are your thoughts on that?
Well, we do, myself and our group, there's
Yes.
a huge number of, since we're the biggest neurosurgical group in the Hudson Valley,
Right.
we see a large number of patients who have this problem.
Okay.
For the most part, the surgery is done from the front. And it seems counterintuitive, doesn't
Right.
it? That you have the spine in the back, but you take the disc out from the front.
Yes.
But as I pointed out to you, it's really easy, the access, and particularly someone like yourself, with
Yes.
with a long, thin neck,
Yes.
access to the cervical spine is very easy from the front. So if someone herniates a disc,
Yes.
and this is me, I can actually, even though I don't have a long neck like you, I can probably get very easily to get to, say, the 5-6 or 4-5 disc,
Right.
take that disc out, and thereby relieve the pressure on the nerve.
Okay. And now you're going to replace it.
Right. Either we're going to place it with either two things. Either with a piece of bone to fuse it together.
Right.
Or in the year 2007, now with some FDA approval,
Okay.
with a device that is an artificial disc and that still gives you the mobility, maintains the mobility in the neck.
You maintain that. And is the body accepting that? What's your experience been so far?
Well, again, our experience with it is short-lived since it was only recently approved.
Okay.
And I think more of them, different companies are bringing out different types of artificial discs. Okay. And I think in the next couple of years we'll have a better idea of how well they're functioning. Right. And if one construct, one model from one company may be better than another. They're all based on different mechanical concepts.
Okay, and it's not being rejected the way we used to hear in the past, like a hip would be rejected or nothing like that.
No, it's in fact many of the same materials, biological materials,
right,
that are used for artificial hips, shoulders, and knees are being used in these constructs.
Okay.
And really, since we're very acquainted with joint replacement,
yes,
this is just another joint replacement. You have to think of it as a joint replacement.
Great. Just the last question. Is this something that's hereditary? Do people get neck pain? I mean, because their mom and dad had neck pain. You know, we ask consultation questions like, what is it in your family?
That's a terrific question.
Yeah.
If you do this, practice medicine in this area long enough, you realize that the patient who comes in with severe back or neck pain invariably has a close relative who has it.
Okay.
Now, is there a clear-cut inheritance pattern?
Mm-hmm.
Like a black mouse and a white mouse mate, they get speckled mice? No.
Okay.
But it's clearly there's something going on, so that a genetic predisposition, I would call it.
Great. Yeah. Dr. Stern, I want to thank you so much for being here. It was very informative, very educational, and you're a great friend, and I appreciate it very much.
Thank you. It was my pleasure. Thank you for having me.
If any of our viewers have a question for Dr. Stern or for myself, you can certainly email us, look on my website, and contact us that way, or you can call us, and we will forward those questions to Dr. Stern, or I will answer them directly. And I hope you look forward to our next show, which is on hearing loss, and we look forward to being with you. Thanks again.